Hi, everybody. Welcome back to the Dental Implant Podcast. I would like to introduce you to a very good friend of mine, actually, Dr. Uzman Haq. And we've known each other for years, haven't we? And it's the more I get to know you, the more I'm convinced we're
Some
just
say
twins.
too long, right?
It's like same interest in everything, right? We've got the same interest in we're interested in films, hero comics. Even things like basketball, we have a shared interest in. It's just like every time that we meet up and we start chatting, it's just like bloody hell. It's like it's like speaking to myself. Really. We get on really well.
Yeah. It's interesting as well because we started to accelerate the implant stuff similar time as well, and then went kind of slightly different pathways. But I remember we were talking about it like mad, 2015, 2016, and we're just this is what we want to go into, and then just really kind of pushed it from there. So it's literally just it's like a mirror, same glasses, same everything.
Exactly. Same reflection of the glasses as well.
Exactly. Yeah.
Oh, fantastic! For those listening, tell everybody a little bit about yourself and what you do, so that they can understand how we're going to be able to help them today. Then we'll get into the nitty-gritty topic of short implants, because this is something we both do. This is something that we both have very strong ideas about, and we both want to impart knowledge. So tell everybody listening a little bit about yourself.
Yeah. So basically, I'm got a practice limited to implants only, and I visit multiple practices. Used to be 16 odd practices that I was at, but now I've got down to 9 kind of core practices, pretty much all the way around the country. Some of these practices there are practices that I basically, mentor other dentists there who are just trying to build up themselves until they can kind of take over themselves in their own surgeries. And other ones there, they've already got implant surgeons, and I'm basically taking the advanced stuff now, because that's all you end up getting referred, right? You don't get referred anything easy after a certain while. I kind of work all the way around the country, and mentoring there as well. So I'm same as you, kind of, that I've really, this short implants topic has been one of these things that I've been really interested in for quite a while. But kind of like a lot of topics, I find it's taught not particularly well, and also at the same time it seems to be the way that it's marketed, whether it's from the implant manufacturers or whatever, it seems to be marketed as kind of like a panacea of just solving many different problems, and that's why I was kind of like, Pav, let's chat about kind of the benefits and pitfalls and all this kind of stuff of doing things like this. You know what I mean?
Yeah. So I mean, I agree with you. The problem is when you start doing these courses, right, or when you look into a certain material, it's always marketed, it's always pushed as a panacea, and a get out of jail free card for all of the problems that you're having. And my perception is that that's not true. There's no one particular technique that is globally accepted for absolutely everything. But what it is it's another quiver in the bow. It's another piece of the armamentarium, which, if used correctly, and we will go into that in a bit of detail now, if used correctly, it can work very, very nicely indeed. Probably the best place to start with talking about short implants, more out of courtesy than anything else, because this is kind of all where it started, is Bicon, right? Mm-hmm. It's Bicon was the original short implant. For those who don't know about Bicon, it's actually a really, really exceptional implant. It's not screw retained. It has a deep, steep locking internal taper, which is actually a true Morse taper, and it's a 1.5 degree internal connection. What that means is once it's kind of like press fit, it's all tapped together. And I've done some of them. They're actually very, very nice. And when they work, because it all cold welds, you don't get any like micro leakage or anything along those lines. If you ever had to dismantle anything, you don't get that horrible stench. It doesn't come loose very often. When people turn around and say they never have a problem with it, it's like, oh, come on, you always have problems. I've seen Bicons.
Yeah.
I've had to move Bicons. I've seen Bicons where they've lost bone. So again, it's not a panacea, but that said, it is a very, very good implant. It's just slightly different because of its restorative protocol as opposed to anything else. But that's kind of like where the short implant concept came from, right? And these implants were generally fairly wide, really quite short, but the way the surface was textured, they had a massive, massive, massive surface area on a very short implant. And I think that's one of the things that we're probably going to be discussing quite a bit here. So from my perspective, Bicon was kind of like the originator, and they've been around for such a time. They've got amazing data on them. You see, I've
years
seen
of data.
Yeah, I've seen Bicons which have been in place like 20 years, look pristine. They're fantastic. They're really, really good.
Yeah, and that's, I mean, the thing is for me, the journey started from Bicon there as well, because initially when I was looking at placing implants there and doing an implant course of, around 2008, that was the first thing that I went to. I went down to Bicon in London, to go on their 2-day course, and then afterwards you're meant to go to South Africa to do the next parts of the course, right? And I was just like, I don't know, I thought I'd basically go and look into other things, but my real short implant journey actually started off with BTI. And I around 2010, 2011, I'm going to butcher the professor's name, unfortunately, but Professor Eduardo Antiua, he came over and he was talking about short implants with his BTI concept, right? And there were certain concepts that he was talking about specifically with the implant, like we touched on with the surface area, with the shape of the implants, things like that there as well. And the way that he described it was, if dentists were in charge of making the Burj Al Arab, the big skyscraper in Dubai, right, then they would have had this skyscraper that was 1 kilometer tall, and they'd put 2 kilometers of foundation down into the bedrock, right? Yeah. And his thing was like, the way that obviously we look at it is basically we're looking at crown to root or crown to implant ratio. And we've always been looking at, right, the implant needs to be much longer than the crown that is over the top surface in order to take the occlusal load. And I remember when I was initially being taught, it was like 11.5 minimum, like 13s you should be putting in, 15s to get your primary stability. And when he was talking about it and he was showing the data about it, it was making a lot of sense, right, from what he was saying. But the difference is that the one beauty of the things like Bicon and BTI, as opposed to many other implants, which I may go into a little mini rant about there a bit later, but basically, as opposed to many of these other manufacturers, these things are purpose designed for short implants, right? Yeah. So you have a lot of situations there where you have many different implant companies who are making implants, but in effect what they are is either miniature versions of their own implant using the same tooling or whatever, or they're a slightly different concept there. I've seen ones where basically it literally looks like the apex of the implant has just been chopped off, and it's like the apex is like in there, and it's just like that. Yeah, it's just like absolute nonsense design, for a short implant. But because of the fact that, everybody's doing short implants there nowadays, every manufacturer has to have their version of a short implant, right? So this is one of the things there for me is like, I probably like you, have many patients there who say, you know what, I don't want extensive surgery. I don't want big grafting. I don't want this. I don't want that. And in some of those cases, short implants may be an acceptable premise to kind of use, right? The problem that I have with a lot of these things is a lot of people just look at the height of the ridge and say, okay, I've only got this height, or I've got this height above the nerve. Let's use a short implant, right? And that's kind of almost the wrong way to look at it, right? So when I'm placing short implants there, you have to, like you said there before, have the surface area, right? So I'm looking at, as a bare minimum, putting 5 mil wide implants in there, right? Because, you know, I've seen people put 4x7s, and we should have actually done, before we started, a definition of what a short implant is, right? Do you want to do a definition of what a short implant is?
You do it, because I hate it.
So definition of a short implant is, you know, below 8 millimeters, basically, right? So, you know, we've, and that's interesting, because nowadays there's a lot of implants that I put in the 8.5s, and, you know, it's just kind of, to me, is that short? To me, 5 mil is probably short now when when I'm looking at these kind of things. But yeah, I'm looking as a bare minimum of having a 5 mil implant in there, 5 mil wide implant. And the reason being is to get that bone to surface contact. And that's quite a difficult concept to teach, right? You know, from your point of view, this is one thing that I learned from you, that, you know, when you're looking at doing a full arch, and obviously you do full arch kind of all the time, you would say, like, look, you know, when you're planning a case, you're wanting that, because you've got less implants in there, you basically got to have your AP spread, obviously, but you're also looking at the most bone to implant contact, right? And that's why we're using 15 mil plus implants, in order to engage as much bone as possible, right? And the problem with many implants there is that they have a shortened concept, but they don't maintain that considerable amount of bone to implant contact. So with a 5 mil wide implant, what are you looking at? You're looking at an 8 mil wide ridge to kind of put something in as a bare minimum, right? Yeah. So you've got some situations there where you've got, you know, you might have a patient who's got, say, for example, a vertical defect there, and you've only got, say, 7 mils to the ID nerve, for example. Or let's make it easier. Let's say 10 mils to the ID nerve, and you want to be super safe. You want to be putting in, say, a 7 mil implant, right? Now, the problem is, if you don't have sufficient width to basically make sure that you've got sufficient bone to implant contact, you are going to have to graft that anyway, right? And if you're doing an extensive horizontal graft, say you've got 3-4 millimeters of bone width, you're doing an extensive horizontal graft, why are you not doing a vertical graft anyway? Even if you're grafting 1 or 2 millimeters there, you're having to do a periosteal release, you're having to do a lingual release in the posterior. So at that point, then the concept of the short implant then becomes, well, you know, it's not advantageous in that kind of way. The main way where short implants work is when you've got lots of width but not much height.
Yes,
and also the quality as well, right? You know, we know from placing implants that you don't want to have huge amount of pressure on the cortical plate, because you'll get resorption, you know, of the plate there. So we try and place implants so it has a you know, good amount of torque and pressure on the trabecular bone, but a very small amount on the cortical plate. Now, if your bone is very cortical, then how are you going to put a short implant in there? You're going to get very little amount of trabecular compression, and if you produce a lot of cortical compression, you're basically wasting your time. Your implant's going to fail there anyway. Yeah. So, do you want to talk a little bit about the designs? Because this is one of my kind of geeky favorite topics, right? Where should we go into that there a bit?
And so I was going to say something. I just lost my track of thought there. What we're actually talking about there is we're talking about appropriate use of short implants, right? And if the ridge isn't wide enough and you're trying to put in a short implant, you might as well just put in a thumbtack, because it's going to be just as good. You know, so these things, they really need to be planned and executed correctly. So I had a revision case the other day where a patient had all on 4, just not cleaning it, got a polite ticking off from me, came back for revision, and his lower left premolar and incisor implant had failed on an all on 4 in the lower, and I ended up having to.
I saw this case. So this is the one that you posted up, yeah?
So I literally pulled the bridge out. It came out. The multi-units came out with it on the other 2 implants. And I was like, oh, great, let me put new multi-units on it. I went to put them on, and the multi-unit screw had fractured because these two implants were doing all the stress. So then I had to reverse those out, and then I could get the screws out, put new multi-units on it. And then I had, on the bottom left-hand side, I had 9 millimeters to the inferior alveolar nerve, and I put in an 8 mil implant. And I was like, I wish I had something brave over this one. But yeah, I mean, okay, so we talked about cortical compression a few minutes ago, right? And this is something that you and I have talked quite a lot about, and it's something that I've discussed. 50 Newton centimeters on trabecular bone is very different to 50 Newton centimeters on cortical bone. And it does not matter how soft the bone is, whatever diameter implant I put in, I will always open up the crestal cortical bone to the same diameter neck of the implant as a minimum, okay? Now, let's go back to Bicon as an implant design, okay? If you look at the Bicon design, the neck of it is actually tapered in. You are never going to have crestal compression when that implant goes in. That is one of the reasons why you get this amazing bone around the neck. You can bury it deep. And the other thing as well is there's no screw. It's just a big, chunky post that gets cold welded into place. Okay. So there's a number of factors that we're talking about now. And two of the factors are macro body design. Okay. That's the width, what the fins are like. We were then talking about micro body design, which is the surface treatment and how to really get massive, massive surface area on these things. And then it's the quality of the connection as well. Okay. So you really want a really good quality connection on these types of implants in order to have success with them. Now, I've seen some data whereby what happens is the narrower the platform of the implant, then the more stress goes around the bone, around the neck of the implant, and the more stress kind of like goes in through the prosthetic connection, etc. Okay. Now, what does that mean? That means that there's been a push a little bit recently where people are saying, oh, you just use narrow diameter implants everywhere, have more bone and less titanium. There's also a study by Block et al. Where they've shown that the more trabecular bone you have, the less success rate, the more failures you have in the medium to long term, which explains why we get so many failures in the posterior maxilla. So really, we want some trabecular bone, but actually not a lot of it. So actually, we should be using as wider implant as what we can without compromising the buccal and lingual plates. So this goes back to what we were discussing, is that when we're using short implants, we really need to be going as wide as possible with a really good connection. And personally, I don't think I'd use anything less than 6 millimeters. If something was available at 5 or 4 millimeters, again, what the data shows it's the first 4/5 millimeters that takes the stress under load. Okay, so for me, I don't think implants are ever going to get to like 2 millimeters in height. That's never going to happen.
Yeah.
And for me, that cutoff point is probably 6 millimeters.
Yeah.
You know?
Yeah. And also just the primary stability is just massively compromised, the shorter the implant becomes. And this is why Bicon's design is just so great. I mean, for me, there's like five manufacturers or 5 real designs from those manufacturers that I would contemplate using for short implants. And
go on, name them.
That was obviously, I would say Bicon, but Bicon, I think you need to, I'm going to split it into ones that I think that an implant surgeon with kind of general knowledge, intermediate level could place, and ones that you need real mentoring to kind of do, right? So I would look at Bicon and I would put that into the zone of I think you need to be mentored by somebody who really knows how to use Bicon if you're going to be placing that, right? The other 4 I would say is I'd be looking at Southern XX. Just because the fact that basically you've got machine neck, you got this kind of connection that is higher up there. You're not having to to worry about the primary stability just because of the shape of it. So, you've got Southern XX, especially the Max one. It's kind of like shaped like a turnip or an onion, right? It's kind of more bulbous in the middle, and then it tapers very slightly further down. And the advantage of that is that your main primary stability comes from the body of the implant, and it increases the surface area massively around there. It also has much more of a kind of flatter apex of the implant there as well. So you're also increasing surface area contact in that zone there as well, apically. So Southern X Hex, the new Straumann, with the very aggressive kind of thread on it, and that's only because of how aggressive the thread is, basically, because just of engaging the bone. Megagen AnyRidge as well in that same category there as well. BTI is the other one. So BTI specific implants that are made for for short implants. They're just designed in a way that, with the hydrophilic, kind of treatment over the surface there as well. They've got deep fins on them. They have a very small taper on the surfaces of them there as well. And the apical design is really interesting, because the apical design is shaped almost like an arrow underneath it. So you've also got even more surface area that bone can basically grow into and integrate into that implant there. So you've maximized as much as possible the amount of bone that you're kind of placing. And for me, should I say the ones to avoid now as well? So
get me into trouble, but allude to them.
Okay. So we don't want to be rude, but I would say in terms of short implants, and I'm not talking about the implant there overall, I would avoid any implant there that looks like a miniature version of a big implant. For example, BioHorizons or Neodent, etc. Their shorter implants are smaller versions of the big one. There's no change in the design of it, and it always strikes me as a little bit odd, because I kind of think, like, if Nike went and got their football boots, and somebody said, "Oh, you know what? Have you got any basketball trainers?" And they're like, "Yeah, okay, here they are." And all they did was take the studs off the football boots and gave you the shoe. You'd be like, "What on earth is this? This is not like fit for purpose. You need something specifically made kind of for that." And that's all of those manufacturers there have made something specific for that specific purpose, right?
I was just going to say, is on reflection on what you were saying, because I was noting this as you were actually saying it as well. They've all got certain design features to try and get as much primary stability and as much surface area onto them as possible. I place Southern Maxes. In fact, I've got one case next week where the bone's so soft it might be Southern Maxes everywhere. But again, you're talking about the BTI with like this arrowhead, the Straumann BLX, which is
BLX. Yeah,
I've seen those. I've used those. They are hyper aggressive. The Megagen I think is actually very, very clever implant. So you've got a certain core size, and you've got what's called a progressive thread. So it enters in one point, and it just so you can significantly under prepare and still get a massive torque on placement from it.
My only caveat with the Megagen is that if I'm using them for short implants there, I would be using the one with the bigger core. So I'd be using a 4mm core. And the 4mm platform, as opposed to the 3.5 platform, because like you're saying,
dense bone. If you're using the Megagen with the really wide fins, it's almost impossible to use in dense bone. It's almost perfect for like really soft bone, but it does struggle in dense bone.
Yeah, and that's where the advantage of things like the BTI come in, because BTI is not so aggressive, but it's just the formation of its taper that basically it matches directly with the drill that you're kind of placing in, and then you have this nice kind of torque pushing the implant in. Southern Maxes are great because, you've got this external head that is over the top that is allowing you to kind of torque it in, and you can really check the exact torque that you're kind of placing it in with. So those are also fantastic implants. My other thing that I would say, and you may not like this, Pav, but basically if you're doing multiples, I would say to use a pilot guide, because you're talking about parallelism of implants. When you're putting in short implants there, if they're not parallel and you've got increased stresses on them because you may have a not passive, prosthetic over the top surface, you're making it way more difficult for your technician to create something there at the same time. But also as well, all of your effects are going to be magnified, right? So you're going to have increased likelihood of a screw fracture, implant loosening. With these shorter implants, there you don't need to lose much bone before the implants had it. And we can look at all of the ways to kind of retain a shorter implant there, increasing the surface area around it, things like that. But in essence, if you start losing height, you're in trouble. So, the prosthetics need to be absolutely on point. And I've started in these short implants in the posterior, actually using multi-units and jigs to make sure it's completely passive when it's kind of sitting over the surface. Because I'd much rather have fit a bridge on there and the patient comes back and says, oh, my bridge is loose, and I'm like, right, okay, it's not passive, let's do the jig again, let's remake this, all this kind of stuff, than have an implant coming out in a ridge that hardly has any bone on it and is then now going to lose more bone, because then you're in big trouble, right? That's
engineering the weak point of the system. That's exactly what I do as well. If you make everything as strong as possible, you still have a weak point. You just don't know what it is. So when we're doing this type of work, it's really important to engineer the weak point to where you can deal with it with any complications quite easily. At least that's a plan. It doesn't always work like that, but that's a plan.
Yeah. I mean, that's the thing is the issue that I have a lot of the time there is, I get mentees quite often saying, okay, can we put in a 6 mil in here? Or can we put in a 7 mil in here? And it's like, okay, well, this is an upper 7, right? And, what's the occlusion like? Have you checked what the occlusion is like in here? Have you talked to the patient there about potentially doing a sinus lift in this zone, or are you just deciding, right, I'm going to put a short implant in this zone because this is the only amount of bone that I've got? These kind of conversations need to be had there with patients, and to use short implants there, they are very, very beneficial, right? But and for me, I'm using them more and more. But at the same time, you need to make sure that you're using them in the absolute correct situation. And quite often I see cases where you've got, a 4 mil by 7 or a 4 by 6 or whatever, and just thinking this is not going to last 2 minutes, right? Because it's on a big crown or whatever, and you're kind of thinking, right, well, if this stays in there 10 years, I'll be very surprised. One of the other issues there as well when you're doing short implants there is that one thing that people don't realize is what you're not correcting your position of your bone crest, right? So you might get a situation where, for example, when you're doing a full arch and you've got to do an alveoplasty, so everything's even, right? So all the ridge is completely flat, and when your prosthesis goes on it, there's no pressure on the prosthesis. It looks even all the way across there. You compare that to when you say, for example, doing, say, short implants, lower left 5-6, for example, right? And you got a 7 back there, which is actually in the correct position, hasn't lost any bone. And you got a 4, which has not lost any bone there either. You may now have a prosthesis which is quite tall. You got to think, is that cleansable? Is the patient able to kind of clean around there? What about the aesthetics? If their smile goes back to the smile line goes back to the 5th tooth, are they going to like the look of this taller, chunkier tooth in this zone? Is that going to be something that is going to be acceptable to them? And also,
sorry, I was just going to say, it's not just that, but when you've got teeth either side and you've got a big defect and you're putting in short implants, it's the same as if you do a nerve lateralization. Taking an impression is a bloody nightmare. because everything kind of like drops away. And then it's like, if you're taking an open tray impression, you can't find the screw heads and everything's really deep down.
Mm-hmm.
So again, it's not just the correct implant design and correct usage of the implant, it's the correct indication as well. Because otherwise it's, you're going to solve one problem and introduce another.
Yeah, and don't ask me how I know this, but actually trying to remove a crown that is on a short implant there, you may have sealed that off there with a silver plug or a PTFE tape or whatever. And when you've got a crown which has a clinical height of 12, 13, 14 millimeters, and in say a lower 7, right? You're going to be there for a long time trying to find this tape and trying to remove it so you can access the screw hole. I've had one case there where I had to do a revision on a patient who had a short implant. Short implant was fine, but the crown had basically chipped porcelain off it, right? So, it wasn't really made properly. It's too, the metal work was too thick and the porcelain was too thin. But it took me about 45 minutes just to get into the screw hole, and then I had to use a driver from a different manufacturer, which was an extra long driver, just to actually get past that clinical crown into the screw, because it was just so deep down.
And then you're trying to get the wide enough so you can actually get
it in. It was a horrible experience, right? And it was made even worse by the fact I didn't put the implant in. Is one of my mentees who had done it, but it's kind of when you're looking at a situation like that, you've also got to be thinking, okay, how am I going to resolve this there in the future? And this is why, sometimes it's easier looking at placing multi-units and things in there and kind of, bringing your platform up. I started doing experimentation with, hygienic pontics and things like that to try and, make it easier for patients to clean. Putting in temporaries there that they can just easily just shove a TP brush in between and things like that. But these are the kind of things you have to think about with short implants that you may not need to with an implant there is at the correct level, because in effect you're working from compromise. The other kind of thing there is when you're actually doing the surgery there as well. So there are multiple different ways to kind of do the surgery. And we obviously talked about, making sure that there's zero pressure on the cortical plate. But, the BTI theory is basically to do slow drilling. So you're doing drilling at 100 RPM without any water. Yeah. And if you try and do that in a thick cortical plate, you're in big trouble straight away, right? You better have the world's sharpest drill to basically go in there and do it. But the whole point in that is that, if you're not working with a guide and you're working freehand and you're talking about, small movements of your hand, maybe side to side, which may have not made any difference there when you're putting in an 11.5 or a 10 mil implant. You're putting in a 7 mil and suddenly you've got no primary stability to the implant because, you've moved a 1/4 millimeter in either direction when you're doing your preparation. And these kind of things there are real definite things to kind of think about. So the planning is also a lot more there as well. Whenever I plan these kind of things, and you should really do this generally with implants there anyway, but especially with short implants, I will diagnostic wax up. I will get a restorative guide made up so I know I'm exactly in the correct position that I want to be. Because I haven't had any of these fail yet. All right. And there's always a time when it's going to happen, but
we all know that.
It will eventually. But the design, when these implants fail, you better hope that they fail with peri-implantitis, right? Because if they fail because you've got a fractured screw or you've got a fractured abutment that you can't get out, you are in a world of pain trying to take that implant out because they are designed to have huge fins on. Integration into the implant, into the apex, into each fin. You know, you might have, for example, like the Southern Max, which is shaped like a turnip, you know, so it's kind of more bulbous in the middle. So, you know, where you're going to tree find? You're going to tree find this, you know, this is going to be audio, right? So I don't know why I'm doing this gesture, but basically, like, I'm just trying to show that if you've got your tree find's going down parallel, it has to go on the widest part of the implant.
Yeah.
So, you know, you might have in a Southern Max that is 6.5 mil wide, and you're going on the widest part of the implant, and you've now created a hole that is 6.5 mil wide from the top to the bottom to get this implant out, right? Maybe even bigger, because you've also got the tree finder around it. And then what are you going to do in order to kind of restore the space? So, you know, those kind of factors you need to think.
Send it to Balaji.
Yeah. Balaji I'd say, sorry, you know, you got to reconstruct this ridge now because this, you know, Southern Max that I put in 10, 15 years ago or something like that. Yeah, hopefully, you'll still be friends and things like that. Yeah. So, I mean, talking of that's one of the other things there as well, is that quite often, you know, I'll have plans sent there to me saying, you know, can you put in a short implant in here? I'm thinking of putting in a 7 mil, for example, in this zone. And I'll look at it and I'll say, well, you've only got 6 mils width. And it's like, yeah, we'll put in a 4x7 or something. It's like, no, it doesn't work like that. You know, you need to have minimum 5.5 mils in there. So we're now going to need to horizontally graft this there anyway. And if the reason why, you know, you've discussed there with the patient is that you want to have a short implant there to avoid, say, grafting, for example. Well, unfortunately, that's not the case now, because you're going to need to graft it anyway, right? And you'll find, you know, there sometimes you're preparing these sites, and you know, some of the fins will obviously protrude buccally because, you know, the ridge is not wide enough. You have to graft it. So when you're grafting to those kind of extents, you know, why not look at placing a longer implant in that zone if you're going to have to, you know, graft to that level there anyway. And you know, it's, I see fairly often, I don't know how often you see it, I see fairly often sites where I think, okay, I could use a shorter or a short implant in here, but it's not as, you know, as everybody kind of says, where it's like, right, okay, short implants are the rage now. You can, you know, let's go and work on it, right? You know, there are not a huge amount of sites where you can look at and say, right, you know, let's go and put a shorter implant in this. The other kind of aspect of placing the shorter implant there for me is kind of always trying as much as possible there to place implants within natural bone, right? And, you know, trying to avoid as much as possible stuff, basically, right? So, you know,
sometimes that means long implants. Remind me, I'll come back to this in a second. And positioning, right, obviously. But you know, when you're kind of looking at a situation like this, you know, say for example you're doing a sinus lift, right? And sinus lifts, you know, traditionally you're probably taught the same way, you know, BioOS with collagen, PRF with BioOS, mixed BioOS, Mineros, whatever. You know, we know BioOS might not even turn over for, you know, 20 odd years, right? Or may not turn over full stop, right? And then you're basically, okay, your implant might actually only be in 4 mils of actual bone, right? And the rest of it is just in stuff, just random stuff in the osteoid or bone-like material that is in, you know, that is in the sinus. So at that point there, are you actually placing you know, a long implant all in bone? And, you know, is it really advantageous to go and do the sinus lift and things like that? I think you need to chat to Stavros and see what his views are about that. There, basically, Stavros is in a league of his own, though. He's another one. He's just like, no bone, let's grow it. You know, you want 3 feet of bone, fine, we'll grow 3 feet.
3 feet, yeah. Well, that's the thing. I mean, this is where the other kind of techniques come in. So, you know, we've talked several times about treatment plans and stuff like that. And you just say to me, you know, I'll be like, okay, let's do this. And you'd be like, no, let's get a pterygoid in there, right? Or, you know, let's engage the bone that's like back here, right? You know, just like, you know, next to the greater palatine, or further back even than that, or let's go past, you know, like when you're raising flaps and you're raising them, you know, so far posteriorly, just to see what your bone is like and your tissue is like and things like that. This is the kind of different kind of ways that you have to be thinking about stuff there as well, rather than always thinking in one particular way, right?
Yeah. So there's probably a few things that I'd add on to that as well. Firstly is, and this is something that I've alluded to plenty of times before, you need to know your implant, you need to know your connection. Yeah? For example, the Southern Max, it comes in all different connections. I just typically use external hex. And external hex is not an unstable connection if you know how to use it properly. Most people don't use it properly, or they're looking at old data. That's why they're running into problems. But for example, if you're using external hex and you go from 4 millimeter diameter to 5 millimeter diameter, you reduce stress on the prosthetic screw by 300%. It's not a small amount, with 1 millimeter difference in diameter. Okay, this is what I'm saying. You need to understand your connections. Okay, is it a bicon type Morse taper, a true locking Morse taper? Is it an ankylos deep steep internal taper? You know, you need to know your connection so that you can understand how you're actually going to execute the treatment, and you need to know when that connection's not suitable so you can use a connection that is. Okay. The other thing that I would say as well, and this goes back to the precision of your osteotomy as well. What you generally tend to find is if you're using a slightly longer implant up to a certain point, if the implant deviates a little bit, doesn't really play that much of a difference. Okay, it's kind of like, okay, instead of being slap bang in the occlusal table of the tooth, it's kind of like slightly leaning towards a cusp. Because short implants are generally, well, obviously they're short, but they're a lot wider as well, is when you get that little bit of a deviation, it tends to kick a lot more. So a slight angulation deviation ends up being a really big difference. So when we're putting these implants in, you've got to make sure that they are going exactly as you actually plan them to do. Something that you're kind of like joking about a little bit before is, I agree with you. You know, it's a lot of people, they should be doing this at least pilot guide and 2 millimeter twist. We were joking about this because you know that I don't use guides for everything. I understand that much experience. In fact, I put up a post not very long ago where I said, I'm trying out this new guided system. What do you think? And everybody's like, yeah, it's really good. And I was like, it's freehand. I caught a lot of people out with that. And the other thing that we mentioned a few minutes ago as well is there is something about engaging native bone. Yeah. So I had a young lady that I did treatment for about a year and a half, 2 years ago. Upper centrals, completely shot. And it was one of those cases, just like, don't want to touch it with a 10-foot barge pole. She was 24, aesthetically demanding. And I understood why. She was, she was young guy, high smile line, massive infections around the teeth. I did staged approach for her. She was so determined to get the best result possible. She didn't wear a denture at the front of her two upper central months. I said to her, any pressure on it? I said, make sure you're not biting onto it. No pressure on it. And she goes, it's easier if I just don't wear it. And I said, well, yeah, you definitely won't have pressure there. And she literally, because her focus was, I want the best long-term result. Now, the protocols that I use, I did manage to regenerate the site and not have any bone or soft tissue loss. And I could have quite easily put in 8 millimeter implants, but that would have landed me slap bang in the middle of the regenerated tissue. I actually used, I think it was either 18 or 20 millimeter implants.
Wow.
So I could engage the native bone apex, right?
Yeah.
And the same is the concept for when we're using zygomatics, okay? Like you said before, the bone that's regenerated when you do a sinus lift is not true 100% native bone, okay? It is some sort of bastardized osteoid type mineral thing. Does it work? Yeah, it can work. But there are also instances where actually anchoring into native bone is going to give you the longevity. So again, this is kind of like the whenever you're looking at a case, right, all of the, I know it flies through your mind, but we're analyzing these all in one go. We're looking at it and going, okay, cleansability, restorability, connection type, body design. Am I going to have problems placing it? Am I going to have problems restoring it? Is there native bone that I can use? Should I be grafting it? All flies around your head at the same time.
Yeah, and this is one of the things, like the way that I would describe the osteoid type material that is in a sinus after sinus lift, unless you're doing, which I've seen, some people do there where they're lifting the sinus and putting Kuru plate in there and stuff. I mean, this is on another level of kind of sinus lift. But when you're doing stuff like that, that's very different. But when I'm talking about lifting the sinus, placing in biomaterial in there, the way I would liken it is kind of like when you place your implant in, it's like cement around a fence post. Yeah. That cement is not glued to the to the soil. It's just there, and it provides retention, right? It stops it from coming out. But at the same time, it's not the same as having your own native bone. It doesn't have the same turnover, the same cells, anything like that. Whatever, you're not sponsored by a biomaterials company, because obviously, like, you're the kind of material that is in there is never really going to be exactly the same, and that's exactly what you're kind of saying. This is why in certain situations, and I've seen people now doing this, people who are more experienced than me and able to do surgeries that are kind of this way, like doing trans sinus implants rather than putting in a short one. Doing a nasalis implant, which then engages to replace a 5, for example. Like, just things like this, where I would just look at and think, right, okay, this is way beyond what I would do. But the concept is beautiful because you're engaging 2 cortical plates to keep this implant in there, right? As opposed to, either a shorter implant there, which stays in the bone that you've kind of got. If you're doing a sinus tap, maybe you might have another 1 or 2 mil, or a longer implant that is engaged in, stuff, basically. Yeah. So engaging that natural bone is paramount. Yeah. But like you're saying, the connection is a major thing there as well. And this is one of the things that, I use multiple different implant systems, right? And, Megagen probably won't like that because one of their main guys. And they're just fine. Well, they know anyway, right? But basically, like, what I look at is like, okay, what can work for each thing? So going back to the sneaker analogy, right? I'm not going to use an ice skate to go and play football, right? I'm gonna use the specific thing that is correct for that specific application, right? Yeah. And there are not only that, the thing that works well in your hands there as well. And it reminds me of a conversation that I actually had at a Rob Beretti's course with one of the other guys there who'd started off with Megagen, right? And he goes, I'm really struggling with Megagen, man. I'm really struggling. I'm like, why? And he said, well, basically because, I used to place Straumann tissue levels like all the time in the posterior, and now I'm placing these Megagens and they just talk out, right? He goes, I'm putting them in and there's 2 mils of implant just sitting above the cortical plate, right? And I had to explain to him that, look, these implants are very aggressive, and you have to make sure that, you have removed enough cortical bone there and use the cortical. Some implants, you don't even have to use cortical drills sometimes, right? Yeah. But especially with non-tapered cylindricals, right? But yeah, with these kind of aggressive implants, you have to go in, remove that cortical pressure that is inside, and make sure your implant talks down, basically. And I know on your podcast and stuff, you talk a lot about muscle memory, right? Yeah. And that's one thing. Like when you're talking these short implants in, once you've done a few of them, you can feel it. You can feel like, okay, this is talking correctly, or this is not really locking into trabecular bone. It's kind of like talking in at the cortical plate, and you can feel it. You can feel that squeaky kind of, feel when it's kind of seating down. Yeah, and you know it, and you know it's not quite right. And the thing is that that's initially when I was taught to place implants, I was told like, right, you have to place 50 before you do an immediate or whatever. Or we want you to do this amount before you start doing implants in grafted bone and things like that. And it always struck me as a little bit of a strange concept. But now I realize it's all about muscle memory. So you actually know what it feels like to actually drill into grafted bone or engage, natural bone, or engage the difference between a plate and trabecular bone. And even with trabecular bone, you have your own issues. You sometimes go into these mandibles and, you think, oh, I've got not much cortical plate here and loads of trabecular bone. It's just all fat. It's just very fatty bone with very little retention, and you have to be careful with those kind of situations. So, for me, short implants, they work, but like anything, they have to work in the right applications, knowing your connections with the right manufacturer for the particular job there as well, and also the patient knowing the information there as well. With the benefits and the limitations there of the treatment.
And this is nice because it ties back to what we started with right at the beginning, is there's no one panacea for absolutely everything. And in fact, it's when you were talking about, fatty bone, I had a little bit of flashback of a patient I had to treat. And this was the worst. I was going to say it's the worst quality trabecular bone I've ever seen in my life. She didn't have any trabecular bone. So this was upper lower dual arch, and literally raised the flap, did a little bit of valvuloplasty, put the suction on, and she literally just had hollow cortical bone. That was it. And it was starting to it was bleeding internally, but it's kind of like with, once the suction was on it, all that yellow fatty bone went away. You looked in it and it was just a crater. And everything was just anchored by cortical fixation. And then I know there'll be a couple of people out there thinking, well, how is that even going to work? Because let me explain this really simply, because so when you traumatize bone, you by drilling it, you induce the healing cascade. Okay. So by going in and doing surgery, although it was hollow, we induced the healing cascade. Yeah, she had a couple of failures, but then when we went back to do the revision surgery for her, she had trabecular bone, which was nice and bleeding. It was kind of like osteoid. So it's, she's stable now. So just because a patient's got one type of bone doesn't mean you can't manipulate it and change it, because you can. It's just how you deal with it at the time, really.
Yeah. I mean, and that's the one thing that I would say is that this is why, with implants, just lifelong education, right? Yeah. Because, one thing I would say to anybody who's kind of listening to this is thinking about, okay, maybe I want to do short implants, or, this is not for me, or whatever. I would say that people have this thing about, okay, I'm going to do an analogy now. People have this thing like about Michael Jackson, right? There's two schools of thought: that was he actually a good dancer, or was he not a good dancer, right? And basically, the people who say he wasn't a good dancer was that he only knew 5 moves, right? He knew 5 moves and he knew how to do them incredibly well. And that was it. He just repeated those 5 moves again and again and again. And the people who thought is a great dancer was like, well, it's knowing those 5 moves to absolute perfection and stringing those 5 moves there together in different combinations for every situation is a thing that made him special, right? So with all of this kind of stuff there, whether you do pterygoids, nasalis, external hex, internal hex, whatever, you have to have the knowledge to know all of these things exist and what might be the best approach to kind of do there for your patient, and be able to kind of think on your feet with things like that. I quite often go into surgeries there where, I'm mentoring people, and they'll be like, right, okay, we want to place a 3.5 10 here, and we want to place a 4.5 by 8.5 here, right? and you'll go in and there's 2 implants on the side. There's a 3.5, 11.5, and there's a 4.5, 8.5, right? And it's like, okay, you are 100% expecting that you're going to be putting those 2 implants in this site.
Yeah.
Everything's going to go absolutely perfect, and you're going to, your surgery is going to be, because at that point you got 0 room for error whatsoever, right? 0 room to kind of maneuver or anything like that. In that point, if you do it and you find that, say half your implant is protruding, from buckley or whatever, you might as well just graft it, close up, and go home, because, your implant plan has gone wrong to start off with. If you're working without a guide, all that kind of stuff there. And, with short implants there, you really have to look at, okay, fine, maybe I want to put a 6 mil tall or a 7 mil tall implant in this zone, but what if I can't? Right? What if I can't do that? What would I do if I can't put that in there? Can I put a wider one in to kind of make sure that I'm gauging enough bone? You can't drill any deeper because you might be in the sinus, you might be, you might be in the nasal floor, you might be in the, in the ID nerve. So, you've got to be thinking about width rather than height. And what happens if you're doing your osteotomy and now you've suddenly got no primary stability? You've got to be kind of extremely careful with that. Yeah. I think the one thing I would say kind of as a final kind of thing is we don't really talk much about where to use them, right? And I would say, I know people who do bicons, and I've seen them in 1s, 2s, 3s. I would never use a short implant in any of those zones ever, right? And unless maybe it was part of a full arch, possibly I'd be thinking about it. Or if it was part of, say, an implant retained denture and I was looking at placing, shorter implants in those zones, then possibly. But I would be looking at, 4s, 5s backs, and really 5s back, because you're looking at anything within the smile line. You're going to get compromised aesthetics, and is that something that the patient is going to want? I mean, you've probably seen them as well. People put them in 1s and 2s, and I've seen pictures of these clinical crowns that look huge, but then the gingival margin is correct. But I would never want to risk that. It's kind of, to me, is too much of a scary prospect to use. Yeah. I mean, would you think about using them in any other zone rather than?
It's again, I find that the most times I use them are actually in the first molar positions, upper and lower. Particularly in the upper, when patients had a tooth taken out a little bit a while and there's been a little bit of a drop in the sinus height. And you're looking at it and going, what's the point in doing an internal or lateral lift when, the ridge is really wide and you can get in a 7 millimeter, it's quite often I'll put in like a max 7.7 and, I get that in at 80 Newton centimeters. I have no issues with it. So it's understanding the implant body design, the implant connection in order to deliver effective outcomes for patients whilst not overcomplicating treatment. But sometimes the treatment, just by the nature of what we do, just ends up getting complicated. I've had some patients who have come to me for full arch at Evo, and particularly if it's a revision case, and you're looking at it and you can't plan. It's one of those where you go, okay, I've got several ideas where I might be able to get an implant in, but already there's several implants in there. They need to be removed first. Then we need to see what's left and figure it out as you're going along. And it's kind of like after my mentoring with Rudy, that's kind of like when I started to realize that I'm starting to get proficient at it, because it got to the point where it's just like, I have no plan going in because I can't plan going in other than having a little bit of an idea, and we can still execute the treatment successfully. And when you can problem solve as you're doing surgery, that's when you're doing something right. That's when you're on the right path, basically.
Yeah, and that's kind of where the idea of going head first into implant surgery comes from.
Yeah.
Right. And, I think you already did one about careers or something, didn't you? Like one of the early podcasts, right? Which I would say people to listen to, because with implants, you can't go in and be like, I'm just going to dabble in it a little bit, right? You have to. There's a lot of stuff you got to buy, right? There's a lot of investment in time, money, equipment that you have to think about. And this is where this kind of thing, you can't problem solve if you only got two implants to place in, right? You've got to have a whole load of implants in a stock to say, whatever. I mean, sometimes I might go in and I might have, only one implant there, but it's kind of like, I've kind of got to a stage there now where if I'm placing a single in between two teeth, I'm 99% sure that I'm going to get the get the osteotomy right and put it in the right position and stuff. Yeah. But when you've got like, when you're doing multiples, or when you're thinking, oh, this bone's a little bit iffy, or if you're doing shorts, you need to have a range. And this is where issues come in off. Doing things minimally, because you're hampering yourself there kind of straight away. So the problem is now is that when you talk about this and you say to people, right, okay, if you want to place short implants there, now it's like there's implant manufacturers have short implant kits, right? It's kind of like, okay, now I've got to invest in a short implant kit, or like
free of charge.
Yeah, exactly. So yeah, I mean, it's one of those things there where it's like, for me, short implants is part of my my armamentarium, and I just I like to use them for a lot of patients where I kind of find, there might not be enough bone here, they might not want to have a graft, but we got a huge, massive ridge width wise, and we can go and do that, or minimal kind of GBR around an implant there, but they've got to be used in the right way.
That's what it comes down to. That's the essence of implantology in every aspect, right? It's pterygoids have got to be used properly, zygomatics have got to be used properly, nasalis have got to be used properly, transnasal have got to be used properly. Everything needs to be used appropriately, and that's effectively what it comes down to. I'm going to do a shameless self-plug now. I've mentioned this on my previous podcast, which has just gone up today. But obviously this video is going to be edited a little bit. I am doing a launch of my new online implant training program, the Academy of Implant Excellence. And I'm just putting all of my knowledge into it, 100%. I'm just trying to give all of my knowledge. The launch offer, please feel free to find me on Instagram, either Dental Implant Podcast, Dr. Pav Carer, or Academy of Implant Excellence. Send me a message. I'll send you over the details, because it is, I will be interviewing you before I even let you onto the course, to make sure that I think that you're going to put in the work and the effort, and that your attitude's correct for it. And the slots are about half gone. And once they're gone, the price is going to go up, because I'm doing this to get the project off the ground, but I know the quality of what I'm giving. I've got a lot of guest lecturers lined up for it as well, as you've seen what I'm planning on giving in that.
Yeah,
as well.
I mean, this is the thing. When you sent me it, I was like, okay, mate, I'm going to have about 2 days it's going to take me 2 days to read this information. But this is the thing, guys. I mean, there's a big void there for a comprehensive kind of implant course which covers a lot of things, and I could talk about it for ages, but I'm not going to bore you guys about it. The fact that this is a selective course is incredible. Like, there's just basically knowing that people have the right attitude and the right approach to implants and learning and all that kind of stuff there, and know that this is a process that is going to be ongoing for forever, pretty much throughout your career. It's just a way, it's just a great way of doing it. And the fact that you have been on multiple different courses in different places, been mentored by the greats, pretty much, right? It's kind of just like you know what works well in terms of teaching and and things like that. And I'm not blowing this trumpet because he's my friend, right? I mean, I would anyway because he's my friend. But at the same time, I've actually read the information that Pav sent, because he sent me and said, you know what, Uz, have a look at it. And I actually feel quite honored that, he would say, look, Uz, could you mind having a look through this, and then reading it. So I read through it and I was like, yeah, this is pretty comprehensive, like literally covering everything that, that you would have to know to kind of start off on implants there as well, and mentoring within it as well, and proper mentoring, not just like, we'll do a few cases and then see you later.
Thanks, mate. So if anybody wanted to reach out to you, or because you're based predominantly in the Midlands, aren't you? If they had any cases for you to look at, what's the best way for them to get in contact with you?
Yeah, they can email me on druzmanhaq@gmail.com, which is druzmanhaq@gmail.com, or they can go to my website, which is implantsbydruzman.com there as well, and go through there. So yeah, if you wanted to, even if you just want to discuss some comic book stuff, you can do that there as well.
Yeah. I don't want to take the president. But not for very long. It moves on to movies.
Yeah. That's what happens. That's my interview, right? I need to, I interview for that.
So it's because we're actually scheduled to watch 2 films next week, aren't we?
Yes. Yeah. Exactly.
Yeah, so so I'm heading out to the Southern Conference. I'm back on Tuesday. Wednesday, Thursday, I'm doing surgery. On Friday, I'm at another conference, sedation update on Remy Mazalam in central London, and then we're heading out to see Black Adam, aren't we? Which
yes, yeah.
Which we're not really
secret cinema.
Black Adam. It's for the other guy, really. And,
it's for the other guy. Yeah, it's for the other guy. But that's.
Then on Saturday we're at
Secret Cinema the day after. So yeah, and both of these are CPD events that Pav is going to do lectures on both of these, right? So yeah, that's the thing, man. So yeah, I mean, it's been great talking to you, like usual, man. And
thank you.
A lot of insights and stuff there. So yeah, I mean, if anybody's got any kind of comments and stuff about it, they can contact any of us, and tell us your experiences with short implants and what your kind of tips and tricks that people might like to hear there as well.
Yeah, we're always up for learning. And if you've had any problems with them, reach out, because, we try to help as much as we can. I mean, that was Prof. Brannemark's original philosophy, wasn't it? That, in order to truly help patients in the next generation, you have to educate people properly and not do it from a point of, well, I'm just trying to get referrals, because to be honest, I don't need the referrals, man. I'm so busy at the moment.
Kind of similar.
I'm teaching because it's a passion, and because I like doing it. I enjoy doing it. I like seeing people progress, and but again, they have to have the right attitude for it. Otherwise, it's just a waste of everybody's time. So that's the reason why I'm doing it. But so all those listening, to all you Titani nerds, thank you very much, and great thanks to you as well. I'll see you next week, mate, and we'll have fun at the cinema, I'm sure.
See you later, man.